Hello, everyone, and welcome to the Equity, Diversity, and Inclusion Virtual Learning Exchange. For those who just entered, there is a poll question on the screen. We ask that you kindly provide an answer. And I'm going to hand it over to Kent.
Thanks so much, Brady, and good morning, one and all, from points far and wide. It's your friendly neighborhood co-chair, Kent Lofsgaard, coming to you from the westernmost Pacific time zone on the lower mainland of British Columbia. And along with Brady, I have the pleasure and privilege of extending a warm virtual welcome to the Healthcare Excellence Canada Equity, Diversity, and Inclusion Virtual Learning Exchange. And as we get started today, we want to make sure that everyone is familiar with the accessibility features that we have on offer. We are hosting this session in 4 languages. There we go. I was just waiting to make sure we had the slides lined up for everyone's convenience. We are hosting this session in 4 languages, including live speaking in English with simultaneous interpretation in French, ASL, and LSQ. If you would like to hear the voice of our French interpreter today, please select French from the interpretation menu at the bottom of your screen. In addition, sign language interpretation is available in American Sign Language, as well as, I'll just say LSQ because my French pronunciation is not up to par. So thank you very much to our capable interpreters for doing what I cannot. Each of these can be accessed from the interpretation button on your Zoom menu. Text instructions explaining this will also be added to the chat box. As I scroll down, in addition to simultaneous interpretation, this session will be recorded, and the recording will be made available via email and via HEC's website in the days following the session. And just as a personal aside, I would suggest that anyone who has not already subscribed to HEC's YouTube channel should do so at their earliest convenience. This session is intended as a space for learning and reflection. The medium is virtual, but we hope the learning will be actual. At the same time, we also recognize that some of these topics may be potentially triggering for some. So we have made supports available in French and English to debrief about the content discussed and to support your well-being. A counselor is available during the session and for 3 hours after the session at the following phone number. That number is 1-855-529-9463. That number will also be added to the chat, and you may contact them at any point during the session. If there is a high demand for this service, you may be asked to leave a voicemail, and your call will be returned from a private number. Sorry, scrolling down again. And my script. We will periodically also reshare that number throughout the session. From me here in beautiful British Columbia, I now pass the presenter ball to another BC, my colleague and co-host Brady Como, a senior program lead with HEC's Patient Safety, Equity, and Engagement team. So Brady, engage away.
Thank you so much, Kent, for just starting us off in a good way, and I really liked that BC transition. Thank you. Hi, everyone. It's my pleasure to be your co-host for today's session. And today, if we could go to the next slide, please. Thank you. I am virtually joining from Healthcare Excellence Canada's office on the traditional lands of the Anishinaabe Algonquin territory in a place colonially known as Ottawa. At Healthcare Excellence Canada, we are dedicated to truth and reconciliation, understanding the need to learn how to foster respectful and reciprocal relationships with First Nations, Inuit, and Métis governments, organizations, and communities. This land acknowledgement serves as an act of reconciliation and a reflection on the privilege I hold in calling this place my home. By acknowledging my own privilege, I honor the sacrifices made by many First Nations, Inuit, and Métis people across the country and express gratitude for their enduring presence that continues to shape our nation. I welcome you to reflect on the lands from where you are joining today. And if you're unfamiliar with what territory you are on and the history that has been built and preceded it, we have provided the link to Native Land Digital in the chat. Next slide, please. For those of you who have joined the virtual learning exchange sessions before, you might be familiar with the aims of this series, but we did want to recap them for today. So the virtual learning exchange is meant to identify and discuss root causes of inequities in healthcare, to learn how to challenge and dismantle systemic and structural inequities that impact individuals and communities through a trauma and resilience-informed lens and an anti-oppressive framework. And it's also to explore strategies to enable accessible and equity-oriented approaches into the delivery of safer and high-quality healthcare. Next slide, please. We would not be able to do this series without the support and leadership of the Equity, Diversity, and Inclusion Virtual Learning Exchange Advisory Group. And so we just want to make sure that we give thanks to this group for providing critical guidance, insights, and perspectives on the content and how we set up virtual spaces to host this series. Next slide, please. I also want to take a moment to remember and celebrate the life of Joanna Ricketts, who was a member of the Equity, Diversity, and Inclusion Advisory Group. Joanna was deeply committed to creating long-lasting and impactful changes to the health system, and we want to dedicate this series to her in honor of her invaluable contributions during the development of past EDI virtual learning exchange series, and also to continue her legacy of fostering community-focused conversations about equity and partnerships with patients who navigate the health system every day. Thank you. Next slide, please. And before I hand over to the session presenter for today, I just want to take a moment to acknowledge that at HEC, we are on a continuous journey to learn and embed equity-oriented approaches into our work. Today's virtual learning exchange is an important step in how we continue this journey of learning as we focus our minds and attention towards disrupting anti-Black racism in healthcare. We understand that this will involve continuous learning, reflection, accountability, and adaptation. We are dedicated to the process of learning, believing it's vital for ensuring safe and high-quality healthcare for all. And we appreciate everyone's willingness to learn with us as we gather from coast to coast today in this virtual space. For today's session, you will note that the chat box has been set up to allow all participants to chat with our panelists, but not to each other. We want to assure you that your comments and thoughts are welcomed at any time throughout today's event, and our team is working behind the scenes to ensure key messages will be shared with the entire audience. We have not reserved time to discuss your questions live today as the agenda is very full. However, your questions comments will be collated and responses will be shared after the event if they are not addressed during the session. I also want to remind that everyone, as Kent had said, that there are access to supports available through, and that will be made reminded throughout the session today and afterwards. I also invite everyone in this virtual space as we gather to approach today's topics with humility, compassion, and self-compassion. It's important that as we collectively want to create environments where everyone is supported and has the space to learn, unlearn, and relearn. And if you find that you need to take a pause during today's session, it is okay to do this and perhaps connect with those who bring you joy. For example, I often find comfort in the presence of my partner or my little Chihuahua dog, who is usually near me, but today I'm in the home, or I should say the actual HEC office, so I don't have them near today, but that's what I would normally do. You also may want to step away, take a moment to rest or reconnect with your surroundings whenever necessary, whether that's during or after the session. Additionally, some may find it helpful to write down or journal their thoughts and reflections throughout or after the session as a practice for processing your experience, insights, ideas, and learnings that come to mind. Next slide, please. Okay, finally, I'm pleased to introduce and welcome Dr. OmiSoore Dryden. Dr. OmiSoore Dryden is a Black queer femme associate professor at the James R. Johnston Endowed Research Chair in Black Canadian Studies, the Faculty of Medicine, as well as the interim director of the Black Studies Research Institute in STEM at Dalhousie University, and the co-founder and co-lead of the national organization, the Black Health Education Collaborative. As an internationally recognized subject matter expert in Black health, Black queer diasporic analytics, and anti-racism health equity, OmiSoore engages in interdisciplinary scholarship and research that focuses on Black and Black LGBTQI communities, blood donation systems in Canada, and anti-Black racism in healthcare, medical education, and Black health curricular content development. I think we might have also shared a bio in the chat. So I'm happy to hand it over to you, OmiSoore, to get into the content, and just thank you so much for being here.
Thank you so much, Brady. Thank you for having me. It's great to be here, and I'm just always going to check that my sound levels are good. You can see me, I'm on screen, I'm not muted. Perfect, thank you so much. Thank you so much to Brady and Carol and the HEC team. It's been wonderful working with you and being here today. And I also want to just to acknowledge that my thoughts are also with Joanna Ricketts' family, being here in Nova Scotia and recognizing, you know, the difficult time that they're going through. Next slide, please. So I begin with this land and ancestral acknowledgement. We use this framework from the Black Health Education Collaborative. We are dispersed across what this region we now call Canada. So I'll be reading this and going a bit slow to make sure that we have the names and the territories appropriately recognized. So the Black Health Education Collaborative acknowledges with gratitude the Indigenous and Afro-Indigenous peoples across Turtle Island who continue to thrive and resist colonial violence while striving for self-determination and decolonial futures. We live, work, and play in various territories, including the lands of the Mi'kmaq, where I'm located, Huron-Wendat, Haudenosaunee, Mississaugas of the Credit River, Cree, Oji-Cree, Gananage, and Dakota, and Dene peoples, the Anishinaabe, and on the homeland of the Red River Métis Nation. We remember our ancestors forcibly displanted African peoples trafficked into Turtle Island as a result of the transatlantic slave trade and the histories and legacies of colonialism and neocolonialism, which continue to impact African peoples and the descendants of the Black diaspora across the world. We recognize that racial colonial violence harms Black, Afro-Indigenous, and Indigenous peoples through both common and distinct logics and actions. And we recognize our responsibility and obligations as African peoples to be good guests on these lands. And we offer thanks to our elders and communities from whom we learn, and may your wisdom inform our actions towards a more just future. We have this land acknowledgement because we recognize that slavery was also a part of the colonial project here in Canada, that Black people are not settlers, and that some of the treaties that were signed before the end of slavery in this region. And if they did speak about enslaved Black people, they spoke about enslaved Black people as goods to be traded. So we want to talk about our relations between Indigenous, Afro-Indigenous, and Black people. For me, recognizing historical Black communities like African Nova Scotian communities, who are the oldest Black communities in the country, and also that anti-Black racism and anti-Indigenous racism are these difficult realities and difficult conditions that can create difficulties in our own relationships. And so here we want to make sure that we're recognizing our unique positioning in this region we now call Canada. Next slide, please. I don't have any conflicts of note to disclose here. Next slide, please. Today we're going to be looking at, and so I'll be introducing and the importance of focusing on Black health through the exploration of the history of anti-Black racism in healthcare in Canada, and understanding privilege and critical allyship and how we can connect with the profound impacts of anti-Black racism in healthcare systems, the way that medicine is practiced, healthcare is delivered, the way in which protocols or policies are created in health systems. And we'll be covering a variety of topics, including the structural impacts of white supremacy and privilege, scientific racism, and how that still informs what we think of as truth in medicine and the realities of Black people, anti-Black racism in medicine and healthcare, and of course, Black health equity in the workforce. Next slide, please. This is the agenda, so you know that I've done the acknowledgements. We will be focusing on Black health and why we're focusing on Black health. And then at the end, when I'm wrapping up, I'll be looking at intersectional anti-racist health systems that are needed in order to support Black health and Black life. Next slide, please. So now I'm going to ask for the survey to be launched. And I'm going to ask you to come into the space. So I know some of you are multitasking. You might be doing some other things, listening to me as a podcast. Some of you are actually in front of your computers. Now, what you'll notice in these questions is that the ethno-racial identities that we're using aren't as specific as we would like, but that's okay. I also know there's about 227 of you currently on this online. And I know that some of you may not have access to this. So I'm gonna, hopefully, we'll get as close to the full participants that are available online. When we end the poll, we'll also share that poll with everyone. I find this such an important survey tool because I think it provides for us a visual representation of what it means to also work in and exist in our society, and who are present for having these conversations specifically around systemic anti-Black racism and how to confront and interrupt systemic anti-Black racism. So we're good. We have around 192, so we can end that poll and show folks what the outcomes are. So what you'll see is the majority, over 50% of the people here identify as white. And then the next largest community are Black communities. And then you'll see the breakdown, South Asian as well, Southeast Asian, the way that we've divided it here. And then of course our relations for First Nations, Métis, and Inuit. And then folks who identify as multi-ethnicity or did not see a reflection of themselves in this list. And I appreciate you participating in that. The next poll, please. So the next poll is going to ask you, where are you in your journey of understanding anti-Black racism? Have you never thought about it before? Have you thought about it, but you're still quite early in your journey? Have you been thinking about it and started to take some action? Have you engaged in content related to anti-Black racism online, but not necessarily comfortable in talking in person with people? Or have you engaged online and also spoken about it personally, in your own professional life, in your personal life? Or have you engaged and are quite comfortable, or, you don't really care? So some people are like, why are you asking all of those questions? I often ask these questions in all of the sessions that I engage in, because the I don't really care, I think, is also a real response to addressing systemic anti-Black racism. Others being really new on the journey and being anxious about it, I think, is also part of the spectrum of responses, real responses that people are experiencing. I do see here right now that some people are quite engaged and are also on their learning journey, and are looking for how to become more involved. This is great. Let's share the results of this now. Thank you very much. And so here we'll see that there's some people who've never thought about it before, some who are still early in their journey, some who've engaged in content online, but not really comfortable in speaking about it in person. But the majority, I think, that we're seeing is folks who are just now beginning to confront this in the workplace, and also really solid in that work. And that's great. Welcome. Thank you so much for being here and for responding. We have a couple more questions. Next slide. Next question. This poll is, who have you had conversations with about anti-Black racism? Who have you engaged in these conversations on anti-Black racism? Coworkers, managers, clients or patients, external partners, friends or families, online communities. We know how important online communities have been. And then you'll see a second question. If you've answered someone else, feel free to specify who those someone else's are. So right now we're seeing that folks have spoken to coworkers, managers, clients, external partners. This is so interesting. Family, friends, online community, we're seeing that. And then someone else, right? So people are also saying someone else. And here you're able to, if you want, you don't need to name names. You could say friend, or you could say, whoever it is that's not in the list, someone else, right? Students, that's not in the list. Government, that's not in the list, right? So you don't need to actually name, say the specific name. So this is great. Let's actually also end this poll. I just have 2 more questions for you after that. So you'll see that lots of folks had said coworkers, managers, clients, external partners, friends and families, online communities, and someone else. And this is great. So of the people who are already in the conversation, this is who they're having that conversation with. And I think this is important for us to remember as we work through today's session. Next poll, please. So this question is, how concerned are you about the impact of anti-Black racism on healthcare in Canada? Extremely concerned, very concerned, somewhat concerned, not so concerned, not at all concerned. How concerned are you about the impact of anti-Black racism on healthcare in Canada? So we're seeing the majority of people are really concerned, somewhat concerned, and very concerned. There are, of course, a few people who are not so concerned and not at all concerned. And I think, again, it's important for us to see the breadth of responses. And I appreciate these polls, because I think it really gets to where people are located in the conversation around systemic anti-Black racism and what that means for healthcare overall in Canada. So this is great, very interesting, very quick responses. We can end this poll and share it with everyone. So we see that it's top heavy, that people are extremely concerned, very concerned, and somewhat concerned. This is important. I want us to really hold this information, as I said before, because it will help us strategize when we get to that part around how do we do this work in interrupting and intervening in systemic anti-Black racism in healthcare. And then the last poll for now, let's go to the next question for now. How confident are you? So we've seen how concerned you are. So this question is, how confident are you that healthcare systems in Canada have the ability to effectively address anti-Black racism experienced? So how confident are you that healthcare systems in Canada have the ability to effectively address anti-Black racism that's experienced by those who receive services or are working in this space? And here you'll see that some folks who are extremely concerned about anti-Black racism, but then are also not so confident in the ability to address and confront anti-Black racism. And we see that some folks are extremely confident and some folks aren't very confident. And if I were doing a different study, if I were able to collect disaggregated race-based data of who's attending and then read that alongside folks who are extremely confident or not so confident, some of the things that we would extrapolate are folks who have often experienced systemic anti-Black racism tend to be in the pool that are not so confident that systems can respond effectively, and folks who are not necessarily the target of systemic anti-Black racism often feel that systems can be are often quite confident. And so that's the piece we will look at as well, get into some of those sticky wicket pieces around where does that confidence lay and lie, and why does it lay and lie there? Let's end the poll so we can show everybody what I'm seeing. So some who are extremely confident, some who are very confident, and then we see it really building here. Not so confident, somewhat confident, and no confidence at all. And sometimes we conflate very hopeful with very confident. And so while folks are hopeful that the system could respond appropriately, some aren't as confident around that. Thank you so much for sharing the poll for me. We're going to take a break now. We don't come back for another question until the end. And I'm going to say next slide, please. So you have been in a session with Dr. Stephanie Nixon, and I just want to thank Stephanie. We have worked very closely together. I worked with her. The Black Health Education Collaborative has worked with her. And so if you've worked with her, you might have seen this prompt from Stephanie, and I use it here with her full consent and knowledge. So as I go through this session, I'm going to ask you to think about and jot down either on your phones, in your notes app, or old school pen and paper, cursive or block letters. What insights are landing for you? How do you feel during this learning and unlearning? And what are some of the next steps you will take? What are the actions that are prompted for you that you will take towards your learning, right? How do we put this learning into practice? And at the end, I'll also come back and ask you about this, but throughout, really, the learning and the feeling about what's happening gives you insight into where there may need to be more learning. And so again, thank you to Stephanie for this. Next slide, please. One resource, unable to show this to you now, but this resource was a documentary or a doc by CBC on what systemic racism looks like in Canada. You can find it on their CBC GEM page. You could also find it on YouTube. I provided the QR code for you to take a look. But when we think about systemic racism, what we mean by that is looking, for example, at how a settler colonial state like Canada, where systemic racism is deeply rooted in the systems of this country, right? So that means that systems were put in place, they precede us, right? In all of the systems that we work, we see systemic racism as present. It precedes us. And what that means is systemic racism and structural or institutional racism were designed to benefit white colonialists while disadvantaging indigenous populations who have lived here prior to colonialism, and of course, Black populations, including Black populations with folks who were enslaved and our descendants, and Black populations who arrived more recently. This power dynamic continues to be upheld and reinforced today, impacting even those who are new to Canada. So I suggest I offer this as a resource for you to review. It's not that long, but it is very important. I use it often and I watch it often because I just find what's being provided there so important in it as a learning tool. Next slide, please. So we're going to talk about why it's important to focus on Black health specifically, Black people specifically. A quick answer to this would be colonization and the continuing impacts of slavery on the lives of Black people today. Next slide, please. But I provide some more information here. Here you'll see that Black people comprise 4.3% of Canada's total population and are the third largest racialized group in Canada. Experiences with anti-Black racism in the forms of social marginalization, health inequities, and biases in healthcare are rooted in the unique legacies of slavery and colonization. And, you know, when we think about how to address Black health and how to confront and interrupt anti-Black racism in healthcare, we need to look at all of the ways, all of the pieces that make up this tapestry of healthcare, whether that's health professional curricula or education, continuing professional development, and how to use the theory pieces in practice, right? So the pieces around critical race theory, but in practice. Next slide, please. When we think about anti-Black racism and the impact of anti-Black racism on health, I think it's important for us to look at what makes Canadians sick. So what you'll notice here, I love showing this to my med students, year 2, med 2 students, because they're often surprised by this data and by this information. So 50% of what makes us sick are the social and structural determinants of health that impact our life. Now it says race here, and it really should say racism, not race, because as we know, and as I'll talk about in a minute, race is a social construction. It is not a biological fact. Even though a lot of healthcare and a lot of medicine and a lot of medical interventions continue to rely on this false belief that race is a biological fact. The next piece is around our healthcare, our access to healthcare, our healthcare systems, and wait times. So if we look at this, 75% of what makes us sick are the intersecting social and structural determinants of health, income, anti-Indigenous racism, anti-Black racism, misogyny or misogynoir, sexism, along with healthcare, whether or not we have a physician, whether or not we have access to healthcare, whether or not we have access to benefits plans. 15% of what makes us sick is our biology. And again, this isn't race, but it's just, you know, how our biological makeup and genetics. And we want to make sure that we're separating this belief between genetics and race. That's really important. Next slide, please. So many of you may be familiar with this image, right? The systemic barriers in society that impact our healthcare for Black people. What I wanted to put here are the social and structural determinants of health that that impact how, you know, our barriers towards our good health, right? What are the things that prevent us from getting to good health? And this is where we'll see sexism, anti-Black racism, poverty, homophobia, transphobia, ableism, the continuing afterlives of slavery. These are all of the obstacles that are in our way that to getting to good health. And again, that is not based on us being Black, but our experiences in society and the structures of society, the things that can prevent us from actually having good health. Next slide, please. Here are some of the, I just wanted to put this quickly at the beginning, some of the clinical outcomes or health outcomes due to systemic anti-Black racism. And so what we know is that, white university educated men have, life expectancies that are 14.2 years higher than those that Black men without high school education. And white university educated women had life expectancies that are 10.3 years higher than those of Black women without a high school education, right? These things, education, as we saw as a social and structural determinant of health, can impact our health outcomes. The prevalence of diabetes among Black adults is 12.9%, which is 2.1 times that of white adults. Again, that's not a race thing, but in fact, something that needs to look at the structural and systemic barriers in our lives. And so it's a social thing. Next slide, please. So what do we mean by anti-Black racism? Here I want to really shout out Dr. Akua Benjamin. Dr. Often when we think of these terms, right, anti-Black racism, they were coined, they were developed, they were researched, they were created. And so it's important really to recognize the researchers and the scholars who have brought this language into our everyday lives. And so here I want to thank Dr. Akua Benjamin, who was a professor at Ryerson in the School of Social Work, the Toronto Metropolitan University now. And she highlighted the unique nature of systemic racism on Black people in Canada and the history as well as experiences of slavery and colonization of people of African descent in Canada. So this is that piece around colonization I mentioned briefly beforehand. It has two prongs. I say this generally. We can think about the attempts to eradicate Indigenous people here, to steal land, claim land, put Indigenous people through residential schools. But we also need to think of the prong of colonization that stole African people from their Indigenous lands through the transatlantic slave trade to bring them here through this practice of slavery and the continuing impacts of slavery that we see today. We've actually had slavery longer in Canada than we've lived without slavery in Canada. And we see the impact of systemic anti-Black racism through the transatlantic slave trade continuing to impact Black people regardless of when they've arrived on these lands. Next slide, please. So when we think about anti-Black racism in research, and this comes from one of my research statements, often when I'm applying for grants, I'll have this question, who do you mean by Black people? But I'll also have this question around, aren't you being exclusionary if you're talking about Black people? And what I wanted to demonstrate in this particular slide from one of my many research projects is that when we talk about Black people, we're talking about Black women and men, Black LGBTQ folks, Black youth, Black birth givers, Black elders, that focusing on Black people is Black folks with disabilities. Focusing on Black people is not actually exclusionary. It isn't deeply inclusive. And if there's this belief that it's exclusionary, then what we're seeing is the minimizing of who we understand as Black people. When we talk about women, are we talking about Black women? In my research, we are. We're talking about LGBTQ folks. Are we talking about Black, queer, and trans folks? Yes, in my research, we are. And that means that we really need to look at the nuance of anti-Black racism and how that looks differently for Black, queer, and trans people, Black women, Black youth, Black people with disabilities. These are the intersecting social realities that we need to think of. And then, of course, when we think about Black people for our research, we really are referring to people of African descent that include Afro-Indigenous people, Black Indigenous people, African Nova Scotian folks, and folks who are multiracial and who identify with their African ancestry. So just a slide really to identify who we mean by the population, who I mean by the population of Black people. Next slide, please. So it's important, to focus on Black people. People ask why. We often hear or are told that racism in Canada is better than in the United States. It's a kind of fiction, right? It comes from multiculturalism, right? We're like, oh, everyone's welcome here. But that fiction suggests that slavery was only something that happened in the United States and not in Canada. Or that because of the Underground Railroad, that Black people have a better experience in Canada than the United States. But that doesn't really tell you But what that doesn't tell you is that the Underground Railroad worked both ways, that Black people fled Canada to go to the United States in the Underground Railroad for a better life in the US. That Black people who came here through the Underground Railroad also left because they were having a worse experience here than they were having in the US. We need to, part of understanding the historical and current anti-Black racism and how it's foundational in healthcare is to really acknowledge the complex interplay between colonialism, anti-Black racism, and health. So I really like this study by the Turner Consulting Group that was published in November 2023. I provide you the QR code here because we're not going to have a chance to get through all of it. But if you need to do a deeper dive, you have the link to allow you to do that. Next slide, please. So child welfare, you'll see that the racial disproportionality rate is actually higher in Canada than it is in New York. And here they looked at the city of Toronto and New York City, where Black children are often overrepresented in the child welfare system, often absconded from their families at a young age and then left in care throughout their schooling experience. And so this is where, when you think of the social and structural determinants of health, and we look at education, this is the reality for Black children in Canada. And we look at family structure, we see them pulled out of their families, and that impacts their educational experience. Next slide, please. If we're looking at carding or stop and frisk, we'll see that the racial disproportionality rate is slightly higher in Toronto than it is in New York City, right? So Black Lives Matter was really clear around talking around street checks, carding. In Nova Scotia, in Halifax, we also see those numbers are high. Next slide, please. Preterm births, we see that the racial disproportionality rate is similar in Canada and the United States. Again, this belief that somehow things are better in Canada than it is in the US. This data really works to dispel those myths. Next slide, please. Employment income, the racial disparity rate is relatively similar, 0.71 to 0.79 between Canada and the United States. Next slide, please. Sorry, yes, you saw the data. I'm not going to go back to that slide. And then the unemployment rate between Canada and the United States, again, the racial disparity rate is similar. Next slide, please. And so I know I went through that quickly, but you have the QR code, and I'm happy to share that in links that come up in the links that are shared with you after this webinar. But so many folks are interested in engaging with anti-racism care and practice, but attempt to do that work by sidestepping the realities of anti-Black racism. So it's really important to note that, it's Black scholars and community workers who develop the very practices of anti-racism. And that's why it's important to keep these power dynamics and this understanding around, race and racism and Black scholars center to anti-racism work. And that's why I have this slide. In order for us to get to anti-racism, to build intersectional anti-racist healthcare systems, it's important for us to really reckon with anti-Black racism and colonialism. Next slide, please. So of course, Dr. Robin Maynard, if you haven't read her book, Black Lives Matter, or Policing Black Lives, State Violence in Canada from Slavery to the Present, I suggest that you do so. She says in her book, the attributes that have been attached to Blackness, subservience, criminality, lack of intelligence, and dangerousness, set up a roadmap for treatment of Black people throughout the 19th and 20th century and into the 21st. Despite the end of formal bondage, Black people's lives would continue to be devalued and their movements subject to surveillance and containment. White settlers and their governments would proactively enforce a racially divided society in which Black lives are worth less. And this is important for us to hold on and grapple with, even though it may feel like difficult knowledge. And then my colleague, Dr. Tisha Massaquoi, tweeted this 2 years ago. Slavery lasted in Canada for about 226 years, and we're now just at 190 years since it's been abolished. This is important to note because people often will believe, will question, why are we talking about slavery? That didn't happen here. It's not important, but what we know about systemic anti-Black racism is developed through the transatlantic slave trade that, in essence, has changed the lives of Black people globally. And I provide a resource to you later on that talks about some of the global impacts of anti-Black racism. Next slide, please. So I'm going to spend just a little bit of time here as we move through. Excuse me, let me have a sip of water. As we speak about anti-Black racism in healthcare, and especially about slavery, people will say, generally, you know, well, slavery, Canada wasn't Canada when slavery happened. Okay. But at the same time, they'll be like, the first medical education program in Canada was in 1824. And what we know is that that opened, which is now McGill Medical School, McGill Faculty of Medicine, that opened in 1824, and that is 10 years before the end of slavery in Canada. So we had a medical education program in Canada to begin training physicians, training medical practitioners at a time when slavery was still practiced in Canada, right? People like to claim that it was an easier, gentler slavery. Let me just say that slavery is not easier or gentler, right? It is enslavement. These things are violent and harsh and have violent and harsh outcomes. And what we don't have is the same kind of depth of research and documents about slavery in Canada as we do in the United States. So I'm going to talk a bit about some of the data that comes out of the United States and the historical documents in the United States. But I want to be really clear here. These medical interventions or medical practices that we have documented through the United States has absolutely informed healthcare in Canada. And we know this, right? We know that if there's a particular vaccine that's being developed in the US, once it gets approved by the FDA, and once it gets approved by Health Canada, comes into practice in Canada, comes into use in Canada. And very rarely, if at all, are people in Canada saying, oh, we can't use that. That's not good for us because it was developed in the United States. Yeah. But somehow, you know, there tends to be this suggestion that if this happened in slavery in Canada, in the United States, it can't possibly have an impact in Canada. And that's just not accurate. So some of this you might already be familiar with. Some of it might be new to you. And I'm going to talk a bit about it historically and then speak about how it's happening now in present day 2024. So the top image speaks about J. Marion Sims, who's considered often the pioneer or the godfather of gynecology, a pioneer in the field of surgery, also, you know, often referred to as the father of modern gynecology. He conducted experimental research on enslaved women between 1845 and 1849. He purchased enslaved Black women. He was gifted enslaved Black women. We know some of their names: Betsy Harris, Lucy Zimmerman, Anarcha Westcott. Of course, it was other enslaved women who were brought to him by their owners. His express reason and purposes was for experimentation. You know, for example, specifically Lucy and Anarcha and Betsy and other Black women had no clue that their owners would lease them out to them, out to Dr. J. Marion Sims, for the purpose of practicing, developing and perfecting gynecological surgeries, often practiced on them in an audience without any kind of pain management, even though pain management was made available. And they were further punished if they were deemed to be making too much noise in response to the pain, told that it wasn't really that painful for them, because, as you know, there is this stereotype that Black women or that Black people do not feel pain in the same way as others, and this was part of his justification. The other image you see here is Samuel Cartwright, who was a Southern physician and a plantation owner. He believed that Black people, enslaved Black people who were fleeing slavery, had this affliction and this mental illness that he coined as drapetomania. He wrote about it in his Negro medicine book. And he also promoted the racial concept of disease, that people of different races suffer different diseases and experience common diseases differently. Some of that belief still is believed today in medicine and healthcare. He also helped perfect the spirometer in order to justify Black people having deficient lung capacities and needing to be harmed in order to develop those lung capacities. And we see that again today. One of the things that we see around pain, there are actually studies that talk about the fact that medical students still believe that Black people don't feel pain in the same way, that are often drug seeking, that are making up their pain levels. We see that now in 2024. And then we see as well the poor health outcomes for Black women and Black birth givers in gynecological care and in birthing care. And some of this happens, again, as a direct correlation. The other piece around drapetomania, that affliction, that, why would enslaved Black people want to leave slavery? We see that when Black people actually speak about racism. Are you sure? Is that the thing that really happened? Maybe you're just reading too much into it. We see that negation of actually being able to document and name the thing that is happening to us. Next slide, please. So for those of you in medicine or in healthcare that work in gynecological care, you may be familiar with the Sims speculum. The Sims speculum is used today. The image on the left is what he developed. The image on the right is what's used right now. It's interesting that this tool that was developed through torture and highly unethical practices is still named after him, as opposed to being named after Betsy Harris, Lucy Zimmerman, or Nacha Westcott. The ways, just a small tool to recognize the ways in which these Black women's bodies were used in this science, but not recognized. Please hit next. There's something else that will pop up on this slide. I use this with my students often. This is from November 2022, where they look at the gynecological anatomy that is named, every part of the gynecological anatomy is named after a man. Some of the bits are very specific, but there are no parts of the gynecological anatomy that are named after women. And again, here we get to see some of the intersecting pieces, like why not name something after Betsy, after Lucy, after Anarcha? But this is, again, this tool cannot be separated from its history or from its creation. Oh, I'm seeing in the chat that the tool is now called Lucy by many gynecologists. Please write about that so I can cite that. I think that would be great. But let's also remember Betsy and Anarcha in that as well. But yes, this is a tool. I did a talk at the ICRE in Montreal a couple of years ago, where I had gynecological surgeons, OBGYNs in the session, and I spoke about the Sims speculum. Many of them sat back with their mouth agape because they're like, I just used that the other day and I didn't make the connection. And this is the part of this work about reckoning with this systemic anti-Black racism, colonialism. The connection is important because it still carries information that we need to address. Next slide, please. All right, just checking in on time. So I'll just speak briefly here. Thank you about that. Thank you for that link. I just want to speak briefly here about scientific racism and race biology. This piece sometimes can be a little more difficult. People think of it as, an old thing. I actually saw this description of scientific racism as the pseudoscience, but it dismisses the fact that back in the day, what we would now call scientific racism and pseudoscience was actually just called science. And much of that science is still used today in 2024. Like that piece needs to be reckoned with. For example, monogamy and polygyny, which are 18th and 19th century schools of thought, that were used to create races, this belief that, white is a race, Black is a race, Asian is a race, right? That these categories, I'm not going to repeat all of them or use the words that were used at that time. Some based on, for example, misogyny developed through the Christian narrative of the Garden of Eden that believed that people may belong to the same species, but were of different races, and those who were white were pure and the original race and therefore closest to God. And this gets changed in the 19th century to polygyny, where they believed that race and species were different. It's from that belief that we saw anti-miscegenation laws, where they believed that Black people and white people marrying was not unholy and not proper, and would produce the mulatto, which comes from this term mule, right? This comes from the scientific belief that there was a time where they believed that if Black people and white people had children, they could not reproduce, their child could not reproduce. Or this early belief in blood donation, for example, that you could not transfuse blood from Black people into white people because it would not be compatible. But then we see how scientific racism informs our knowledge around correcting for race, for example, in kidney functions, which often results in the fact that Black people need to be much sicker before the care plan can be put into place, because the correction for race for kidney functions is still being applied. It's something that's no longer being applied in the United States, but in Canada, I've not yet heard of a jurisdiction that's stopping that correcting for race, and other ways in which it manifests. And then the other piece that we see that in is around the use of the word Caucasian. Caucasian comes from scientific racism, as do other racially charged words that I won't repeat here, but we still use it today in patient notes, when talking about patients, when talking about white people, but really we should be just saying white and moving away from this practice of Caucasian. And I don't have time to get more into that, but it really does come out of scientific racism. Next slide, please. So I'm going to speak briefly around how we speak about manifestations of whiteness, which is also something we need to look at around systemic anti-Black racism or structural white supremacy. This was developed by my colleague Sume Ndembe Ayo, who will be meeting together with you in June. Where we look at white supremacy, we look at internalized, interpersonal, and whiteness in institutional practice and policies. Next slide, please. This book came out recently. It's a resource for you. In this book, they talk about whiteness as the very construct that allows white supremacy to flourish. It's the lie that creates the norms, and like any good lie, it changes regularly to fit the wants and needs and desires of white people. And that may feel harsh and sound harsh, but one of the important pieces around reckoning is actually having the difficult conversations that may feel like an accusation, but really are an identification of what's occurring. Next slide, please. So in white privilege, a term coined by Peggy McIntosh to talk about, to recognize that invisible knapsack that people walk through that who are white. In no way did she ever mean that meant that people who are white don't have difficult lives, but also was trying to grapple with the ways in which there are invisible privileges. I'm sure that Stephanie Nixon spoke with you about that through her discussion of the coin model. Next slide, please. When we think about structures of white supremacy on the whole, we often think of whiteness as neutral, as normal, as colorblind, and therefore it remains largely invisible. It's something that if we name it or out it, people can feel affronted by. But also it informs these pieces around, who has the right to be there and who doesn't. Next slide. And this is really why it's important for us to think about objectivity, neutrality, and colorblindness, because people claim this as an idea of, I treat everybody the same. We don't. We just don't. So it's something that we need to step back from, or we're coming at this in an objective way or a neutral way. But when we do that, we're actually not actively addressing the racism in the room, which is why I really like this image. Many of us, regardless of our ethno-racial identity, might claim a neutrality or objectivity or a colorblindness, but in fact, that only serves to perpetuate and further support structural white supremacy, because as I said, it's doing nothing to actually confront or address or interrupt the racism. And in order to do that, an action, a purpose, a step needs to be taken. Something needs to be done, as opposed to this more passive claim of neutrality. And this is why it's important to look at, the intersectional anti-racism healthcare and the purposeful steps that we need to take around accountability, but for reckoning with systemic anti-Blackness. Next slide, please. So when we look at this, I hope this is wide on your screen. If you're looking at a phone, it's going to be a little difficult to read. But if we move away from this kind of race neutrality and also away from race-based medicine and look towards or race-based healthcare practices and look towards race-conscious work, right? Actually understanding that racism exists, that we need to look at how anti-Black racism pre-exists our arrival into a space or the work that we're doing, then we see that this over-reliance on race as a social power harms us and doesn't allow us to move forward, that we need to look at how structural anti-Black racism is affecting the work that we're doing, that we need to look at the consequences of anti-Black racism on health. And if we think back to that slide around social and structural determinants of health, or that slide about the objects in front of us that prevent us from getting to good health, these are the pieces that I think are really important for purposefully looking at reducing health inequities and health disparities, but also creating a health system that can appropriately address systemic anti-Black racism. Next slide, please. You might be familiar with this image of overt white supremacy and covert white supremacy. We often think of some, that stuff above the line, but rarely think of the pieces below the line. We don't have time to do this here, but on your notepad or on your phone, just take a moment to think about, which one of these things have you used, or which one of these things have you heard being said. This quote by Benia Siva, the language of color blindness is slippery, apparently contradictory, and often subtle. And just some of these things that we've seen pop up that people say because I think it, or people act upon because I think they think that that's the way to equity. And in fact, it's not. The way to an anti-racism practice is really about having those difficult conversations and naming the thing that we'd rather not have a difficult conversation about. Next slide, please. I think I said this earlier, sometimes people say, but I'm just nice. We've heard that I'm nice and I'm colorblind, I treat everybody the same. But really what we want to do is get to kind, willing to make waves, willing to have that difficult conversation, willing to speak up and take a stand, willing to be concerned about doing what is right. Yeah. And that's the kind piece that is really important for our commitment to an intersectional and anti-racist healthcare practice. Next slide, please. So just briefly, I want to identify, some of the challenges around lateral violence. When we think about lateral violence, we think about the anger and the rage, which is often directed towards members within marginalized communities. It's displaced or oppressed communities or communities that have been made marginalized. Where we're arguing amongst each other as peers, as opposed to focusing on the structural white supremacy and the systemic discrimination and the institutional racial gaslighting that's actually the cause of the harm that we're experiencing. So sometimes we'll combat with one another, as opposed to turning towards the thing that needs to be dismantled or turning towards the thing that needs to be interrupted. And so this piece is in need of a larger conversation, but I wanted just to share these slides with you and this information with you. Again, to twig maybe some of these are things that you've heard or things that you've said, and to get a sense about how they may be, unbeknownst to you, contributing to a practice that further entrenches the racism that we're looking to disturb and disrupt. Next slide, please. This is from the Black Nurses Task Force report from 2022 that gives an example of how anti-Black racism is a form of lateral violence and where we see it in the nursing profession from that report. I provide a link to that report later on in these slides. Next slide, please. And just before here, I think we're good here. We're going to move on to some of the steps we can take around intersectionality and anti-racism, holding on to that information around the continuing impact of slavery and anti-Black racism to this day, really pulling that information that we just spoke about and holding it as we move into what steps and actions and practices can I engage in, understanding these realities around systemic anti-Black racism. Next slide, please. So a key benefit of an intersectional approach is one that embeds an understanding of our complexity in our exploration of stigma on health, clinical settings, diagnoses, protocols, employee practices, environment, climate. I want to give a caution here to be very careful of any epidemiological articles you read that are written about intersectionality, but do not address those components of racism. They treat it as just an individual item in a list of items, but don't understand it as the foundational work of intersectionality. Dr. Kimberly Crenshaw, who coined this term, who worked with others like Dr. Patricia Hill Collins and Professor Bell Hooks, really to understand the complex connections, outcomes, and opportunities that arise from multiple simultaneous forms, but also the power of racism, the power dynamics of racism. When you take that component out of intersectionality, Dr. Kimberly Crenshaw calls that the gentrification of intersectionality. So in all ways, when we talk about intersectionality, we should be talking about structural white supremacy, systemic anti-Blackness, and the way that racism informs our various identities. Next slide, please. So this is a working description. That means it's something that needs to grow and develop. It's not static. An active process, remember that piece, what step do we take? The kind, being kind, having the difficult conversation. An active process of identifying and eliminating anti-Black racism by changing systems, organizational structures, policies and practices, peoples and attitudes, so that power is redistributed and shared equitably. Next slide, please. And what does that mean when we think about equity, diversity, and inclusion? You've probably seen this slide, this image before, the 11 deadly sins of diversity programs. Again, this is for folks who are trying to get to anti-racism without kind of reckoning with those other pieces, right? What is the why? Why are we doing this work? What is the focus? What are the activities? Are we more focused on the activities than we are with the results and the outcomes? Are we more focused on, for example, attending a webinar than actually putting the steps into disrupting systemic anti-Blackness, right? So this is one part, but there's another part. How do we change the infrastructure? Next slide, please. I think, I wanted to include this as an example. When we think about understanding the difficult work in addressing and interrupting systemic anti-Black racism or structural white supremacy, moving past this, race neutrality. When I think about, for example, gender affirming care, how do we engage in a holistic gender affirming care, one that addresses, the impacts of systemic anti-Black racism or structural white supremacy, and how we understand, for example, gender affirming care. Next slide, please. So why does anti-racist leadership matter? You may have an answer to this, but I think it's important for us to recognize and build into our employee expectations, build into our leadership expectations, that it's a way we get to systemic change, again, looking at outcomes as opposed to just the activities, moving beyond just momentary allyship, I know there were many people that had a black square for Black Lives Matter, but now thinking we're beyond that, we see that in funding as well. Funding for looking at addressing systemic anti-Blackness is being reduced as opposed to expanded. These are not time-limited pieces, but actually larger pieces. And so really looking at deeper actions, commitments, and accountability. Next slide, please. And this is what it looks like. It can look, you know, like this whirligig where it's just going around and you're thinking, oh my gosh, how am I going to get to this? How do I do this work? Why does it feel so complicated? And it is complicated, and you will fail and you will have difficulties. But that's why we are committed to longstanding change. And because our lives shift, so do we have to go back and rethink some of the actions we've taken in the past. Next slide, please. Actions and accountability really, really are difficult. Really are difficult in terms of how do we do that difficult work, right? How do we set our egos aside to be like, oh my gosh, I did something that's really causing harm. That may not have been my intention, but it's definitely the impact. And how do I expand that from individual work to systems work? I know that some people are here only over their lunch hour and will catch the last piece at the end and need to step into their next meetings. I understand that. But I am going to be wrapping up soon, and you will be able to see the rest of the recording at a later time. And I'm really looking forward to our session in June. Sound quality is shaking is for some people. Let me know if it's on my end. I am in Halifax. And so sometimes, I don't know, it could be raining or windy outside and my Wi-Fi will be acting up. So as we know, race is neither scientific nor biological. Health disparities experienced by Black people are the product of structural and systemic injustice and violence. Next slide, please. I'm going to move through this a bit quickly, but you will see it in the slide, in the recording. This is some of the accountability that we need to think about in terms of Black racial equity. How are the issues being defined? Remember that the survey I did earlier, one of the questions, you know, do you believe that institutions can deal with this in an effective way? And people are like, some people are like, yes, absolutely. And others were like, I'm not sure how confident I am. Part of being able to measure that is to determine how is it being defined? What is, how are we defining effective outcomes? How are we defining effective results? And who is determining whether something's effective or not? So just some of the questions to think for yourselves in terms of how do we address systemic anti-Blackness? Next slide, please. Yes, wrapping up. Next slide, please. So I wanted to provide with you, provide you with some resources. You'll also get this in the link when we move forward, when you get a wrap up of this. This special issue happened in I want to say 2022, it could have been 2020, yeah, 2022. And it was a lot, it took a lot pulling this together. This group dealt with a lot of structural white supremacy and systemic anti-Black racism through working with the CMAJ, through working this process. And even when you read the introduction to the special issue, you'll notice that the editor also speaks about the realities of structural white supremacy and systemic anti-Blackness that were obstacles in getting this special issue together. Up until this time, CMAJ, relied on a race-neutral, objective publishing practice, which meant that Black researchers en masse had not been published in CMAJ in the length of time that CMAJ was publishing. And that's not because Black people are not good researchers. Internationally renowned Black researchers were being published in the Lancet, the BMJ, and other journals, but not in the CMAJ. That is not because we don't have internationally renowned Black researchers, but that is because of structural white supremacy and systemic anti-Blackness. It's not unique to CMAJ, but it is the body we were working with. So here's, this is one, it's an example of the struggle it takes to do something you would think would be easy to do, which is have a special issue on Black health and anti-Black racism in healthcare and Canadian healthcare. Next slide, please. Some other resources for you, how to call out racism and enact allyship, what steps can you take, and how to respond, a framework to teach how to become an active bystander, upstander when facing microaggressions. Next slide, please. My colleague and I, Dr. Ani Norm, wrote this article in 2021 in the CMAJ. And I think at that point, we became the second and third Black researcher to be published in the CMAJ. Again, that's not because there aren't excellent Black researchers, but because of systemic anti-Black racism. Next slide, please. This special issue with healthcare papers came out in October 2023. With responses, I wrote the lead article with responses from people from across the globe, South Africa, the United States, Aruba and the Netherlands, and the UK, speaking about global anti-Blackness. It's something I would suggest in various aspects of healthcare. So I suggest that to you for further information. Next slide, please. And this is the Black Nurses Task Force report that I shared with you. I just you to earlier, that looks at what can be done in nursing, but also healthcare overall. Next slide, please. This framework for public health looks at anti-racist praxis and the importance of focusing on race consciousness and the four foci that they use in terms of understanding race as a social construct, understanding the importance of intersectionality, and understanding critical approaches to this work. So when we think about race consciousness, you know, this awareness of that racism impacts how decisions are made, how policies are put into place, what the environment looks like, contemporary mechanisms, understanding how racism is something present, not just a historical fact, but precedes us into our spaces, is already present. And when we talk about praxis, what we're talking about here is the action of engaging, applying, realizing, and putting these practices into place. Next slide, please. I didn't get a chance to talk about the importance of data collection. It is important, not in order to measure the impacts of racism in the workplace and hiring practices and in protocols. You'll see here from this EGAP document, it also means uncovering the inequities. So we call it race-based data collection, but in fact, we're collecting information that allows us to assess the impacts of racism in our workplace or in policies or things of that nature. Next slide, please. Just quickly, you know, naming racism is not unprofessional. Often Black women are, and Black people are called aggressive or rude or abrasive. You know, perhaps we've stopped calling white women or women, perhaps we stopped calling women hysterical on their job for, you know, responding to something that's inappropriate. But Black women are still, and Black femme presenting folks are still called aggressive. Black men are called unsafe and dangerous. And, you know, Audre Lorde in her essay, The Uses of Anger, Women Responding to Racism, says, and I quote, "My anger is a response to racist attitudes and to actions and presumptions that arise out of those attitudes." You know, there's enough really terrible stories of Black people in healthcare. I think of Samuel Uko from Saskatchewan, who was having a mental health crisis, and he was met instead with police and security threatening to arrest him, only to later take his life. Later that same day, when he was chased out of an emergency room, to later take his own life. We have other stories like this as well. Around systemic anti-Blackness and the ways in which Black people's responses to harmful experiences are often criminalized, and then they are either delayed care or denied care. So no, naming racism is not unprofessional nor rude. I'm still really upset by the amount of students that are often taken in front of professionalism committees because they're talking about the racism that is happening in their education experience. Next slide, please. But having said that, it's important to provide you some details. Dr. Sarah Ahmed has written a number of books. And when you do talk about anti-Black racism, because you're the one that exposed the problem, you're often then considered the problem. And people who are talking about racism are really making the complaint because they believe that something else is possible and available to us, but are rarely rewarded for making that complaint. Next slide, please. So again, I'm a professor. I love assigning readings. Here are some really great documents that texts that I think are really useful for you on being included, racism, and understanding institutional life, the equity myth, and yes, and her book's complaint. Next slide, please. So, can you put up the last poll, please, as we move on? The very last poll, please. Today, I learned something, yes or no. For those who are still here, please let me know. And again, if you didn't unlearn anything, then that means you were one of the people who were like, oh no, I've been doing this. I'm well versed in this. I've had this conversation around this. I appreciate you telling me about that. Next slide, please. Or sorry, before we move on. Again, think through what is your role in addressing anti-Black racism? What is the thing that you can do, that you can step into in addressing anti-Black racism? Next slide, please. Yes. Sometimes people don't think of this work as, research. They think of it as, my lived experiences, because I didn't put enough graphs up, or I didn't say, this is the outcomes of this particular survey. But this is also research. And so my research assistants always put this slide in. Let's think about how we cite narrative discourse, narrative research in the work that we're doing around systemic anti-Black racism. Next slide, please. Session 2, June 19th, with my colleague, Professor Sume Ndembe Ayo, Approaches and Theories to Understanding Black Health and Systemic Anti-Black Racism, Part 2. We'll see you there. Next slide, please. We will be talking about many things, including the Black Health Primer and their learning pathways. Very happy to share that with you at that time. Next slide, please. And if you need to reach me, this is where you can reach me. Thank you so much. I went 2 minutes over. And I'm sorry we're not in the same space, but thank you for all of you that have joined online today. I was able to, oh yes, let's share the poll. Let's share the poll. I was able to catch some of your questions. I didn't get all of them, but yes. We can end the poll and share it with everybody. I can see a majority of people have felt that they have learned something new. Some people said, no, it's okay, I'll get you next time. And I'm going to turn this over to Brady and Kent to wrap up. Thank you again for everyone who attended. I know some of that information was difficult to see and to witness. So please make sure you do something for yourself that's kind and gentle. And thank you again. We'll see you in June.
Thank you so much, Dr. Dryden, for that bountiful feast of valuable food for thought. And one thing I think that stood out a lot for me is I think that a lot of us in Canada, have the misperception that Canada's experience of racism is comparatively benign when we look at ourselves in contrast to the United States. Something that parts of your presentation reinforced for me today, is something I've also been saying for years, is that Canada, both historically and presently, has many of the same sociological problems that the United States does. They might just seem smaller in comparison because our population is smaller. So, and again, parts of your content presented today reminded us of those historical and current realities. And having said all that, and recognizing that much of this food for thought might be discomforting to digest, on this slide, we don't just have soothing, colorful icons, but it's also a reminder that supports are available. There's an opportunity for you to write down and journal your thoughts and reflections, reconnect with your natural surroundings, connect with those who bring you joy, take a moment to rest, and remember that we are all meant to practice humility, compassion, and self-compassion. And one thing that I like to add often in times like this is that especially when things seem challenging, let's not let the fear of everything we can't do keep us from doing everything we can do. Next slide, please. And just a reminder again of the number for the counseling services that will be available for the next 3 hours or so. That number again, 1-888-829-5815. And Dr. Dryden had mentioned the next chapter in this journey together, and the next session that we have scheduled is on June 19th, 12 p.m. to 1:30 p.m. Eastern Time, discussing approaches and theories to understanding Black health and systemic anti-Black racism, Part 2. So if you thought Part 1 was good, I hope that you will join us for the literal second course in the serving of this ongoing collective conversation that we're having on these important topics. And thank you again to Dr. Dryden, and thank you to everyone for joining us from wherever you hail today.
And that concludes our webinar for today. Thank you, everyone. We're happy to give you 3 minutes back to your busy weeks.